Hey, everybody, and we're live with Understanding CBD. Today, I'm your host, Stephen Wallman from Wallman's Apothecary, and we have another incredible topic for you this afternoon and an incredible speaker. We have Renee Reisinger, a nurse practitioner, as also a graduate of the University of Maryland School of Pharmacy, master's in cannabis sciences. And we're going to talk about something that is controversial, really, today, and that's breaking barriers down with medical care and access to care. And then how does cannabis play into that? And, let me bring Renee in here. Hey, Renee.
Hi.
There's that great smile. I love it. And just so everyone knows, we're doing this live. I'm not a trained actor. Neither is Renee. She's a nurse practitioner and an educator. We're doing this because we want to reach people that are new to cannabis, whether you're a patient or you're a practitioner or clinician. And that's the intended target for this information. So if you know someone that is either struggling with some sort of disease or in need of some sort of treatment, this is good information to get out to them to help navigate what's going on. So, and Renee, thanks for being here today.
You're welcome. I'm glad to speak with you.
Yes, and we get better every week, I promise. It gets a lot more fun too. And this topic is something that I know is near and dear to your heart, because from being in the healthcare system, you've seen firsthand some disparities in how there can be how people can be treated.
Yes. So this year I've been a nurse for 40 years. I love saying that. I've been a nurse practitioner for 17. Yeah. Healthcare is the only thing I've ever done. And, as the years have gone by, I've seen great strides in Western medicine. And I've seen programs that are out there that are designed to improve the health of the population. And public health is near and dear to my heart. In the middle of the COVID epidemic, in December of 2020, I was speaking with some people about this a week or so ago. And I think because of COVID and working through COVID as a frontline healthcare provider, being in school, I didn't really realize it happened until about a year later. But in December 2nd of 2020, the United Nations, under the recommendation of the World Health Organization, removed or rescheduled cannabis as a medicine that had no medical value and was highly addictive. And it was rescheduled and recognized as having medicinal properties and some addiction potential. I believe when that happened that 53 countries around the world also adopted that stance. And adopted it into their healthcare systems. The United States was not one of those healthcare systems that adopted that. Cannabis is still a federally scheduled Category 1 drug. It's considered illegal with no medical use. We know it has medical use because we have a state university in Maryland, the University of Maryland School of Pharmacy, that with the blessing of the previous Maryland General Attorney, Mr. Frosch, approved the medical cannabis science and master's degree program at the School of Pharmacy. And the program would not have rolled out if it wasn't recognized by the university and by the state of Maryland that cannabis is medicine. Maryland has had a robust medical cannabis program since December of 2017 is when the first dispensaries opened. I believe legislation passed the Natalie LaPrade medical cannabis program was voted into law, and the commission was formed in 2014, 2015, and in December of 2017, the first dispensaries opened. So it's great that medical patients have access to cannabis in Maryland. All of the states in the nation that have medical cannabis programs, you need to have disposable income to afford the cannabis. I think there may be one or two or more states that have recently legislated for their state-funded workers' comp programs to start covering the cost of cannabis because they cover opioids. So I think, slowly states are starting to recognize cannabis as medicine, but it comes back to the question of affordability. And I think, as I've stated before, as a nation, who are we? Are we a nation where you get health care if you can economically afford it? Historically, no. A lot of our healthcare institutions have been set up to serve the poor. There's EMTALA regulations associated with every ER in the U.S. where
what is that? What's that called?
EMTALA. It's a federal regulation where if somebody presents to an emergency room with a complaint, they need to receive a medical screening to deem whether they're stable and can be referred out or whether they need to be seen. So, our ERs are set up to try and, give people that don't have health insurance or don't know where to go access to care. Nobody can walk into a dispensary without money and get cannabis. People that are uninsured can go into an ER and, get some basic medical care. Not so with our medical dispensaries. This is a problem, that's bigger than you and I, but as a systems issue, who do we want to be? I know I have said before, to quote our beloved Congressman, Elijah Cummings, we're better than this. We can do a better job of serving people that can't afford medical cannabis. And I think this is something that really needs to I think 37 states now have medical cannabis programs, but it's very difficult, for patients and providers when we try to go through or state to state, and you talk about, housing, job issues, job protection, access to care. We need to come up with a better plan so that everyone has access to cannabis medicine, and it's not just in certain states.
Yeah, that you bring up so much there. And just so you know, there's someone watching on Facebook that just typed in awesome. So they're really happy with what you're saying and the conversation. So I think we should keep it up. But you really talked a lot about there, and I want to ask you a couple questions about it, because the first thing was in December of 2020, the World Health Organization made a recommendation to the UN that they should reschedule cannabis from something with no medicinal properties and no medicinal value. And then they rescheduled it to something that does have medicinal value. And of course, there's, like everything, you've mentioned this many times. Every time you talk about cannabis, you talk about there are risks. And there's risks to it too. So the World Health Organization made this recommendation. United Nations says, hey, let's take this step and make this more adjusted to the reality of the new science that we're learning, that there is medicinal qualities. And you even back that up by referencing the master's degree program at University of Maryland of cannabis science by the pharmacy school. So there is evidence of medicinal properties here. And there were a number of countries that adopted this, but the US didn't.
Correct.
So that's one thing I wanted to really just point out here. And because of that, each state now has a different sort of iteration of how can we, get this cannabis, freed and through to the people. So that was one really important thing that I just wanted to make sure to highlight that you said that I took away because I wasn't familiar with that. And the second thing that I wanted to talk about that you brought up, and I want to dig a little more into this, is the way people have access to care and they don't have the money to pay for it, or equal access. So there's different groups of people, and you've sent me a lot of articles and educated me over different protected groups, whether it's because of race or geography or sex, that they don't have the same access to care even without cannabis.
Correct. And, I think that we have known this as a nation, as we have, whether we have talked about it in our classrooms or not, but the 400, and actually it's, 600 years of systemic racism and inequalities that have existed in our nation. And, if you listen to, Stand on the Shoulder of the Giants that came before us, I love to listen to Equal Justice Initiative founder Brian Stevenson lecture. He's a wonderful lecturer, and he talks about, who are we, as a people. And the only way to overcome these issues is to discuss it. You can't have the elephant in the living room that you don't talk about. JAMA, the Journal of American Medical Association, on May 16th of 2023, put this paper out. Excess mortality. Oh, I'm trying to show it. Okay.
Here, I can give you a little bit more space here. Let me remove myself from here.
I didn't hear anything about this on the news media, and I read the summary of it, and it's pretty important. Excess mortality and years of potential life lost among Black populations in the U.S. And I looked at Medicare data over a 20-year period, and this was astounding to me. And I think this is something that we need to be talking about. And why is this? We need to look at this.
Summarize that for us. Now we can put that in the post if anyone wants. We can put it in the comments. But can you summarize what the article's talking about?
So the question was, how many excess deaths and years of potential life lost for the Black population compared with the white population occurred in the United States from 1999 through 2020. This was published in the Journal of American Medical Association this month. Findings based on Centers for Disease Control and Prevention data, excess deaths and years of potential life loss persisted throughout the period, with initial progress followed by stagnation of improvement and substantial worsening in 2020, which is when we were in COVID. And I think I've brushed on this before. The Black population had 1.63 million excess deaths, representing more than 80 million years of potential life lost over the study period. What can we do can we talk about this, and what can we do to improve this?
Yeah, go ahead.
This is bigger than me, but I'm bringing it to the table so the people out there that are much smarter than me, can start talking about this.
Where are the rooms that this should be talked in? Who are the right people to talk to about it? And because I know a lot of people, of course, a lot of people are busy with their own lives and they don't really care about it. They're too busy with other things. But there are a lot of people that do care. And who do they talk to about this? Do they call their representative? Do they reach out to certain insurance companies? I mean, who do they have this conversation with?
As a healthcare provider, these are conversations I want to be having with other healthcare providers. Did anybody see this study? What do you think? What are your thoughts about cannabis as medicine? And I know I've said before, as a healthcare provider, we have an ethical obligation to continue to educate ourselves. So what other healthcare providers are educating themselves about cannabis? And if 53 other countries in 2020 recognize cannabis as medicine, where does the U.S. stand on this as public policy? And how do we improve health outcomes? And as I said, people now that can afford cannabis medicine, you need a disposable income to afford it. Cannabis isn't free in the dispensaries. Before cannabis was made illegal, and actually, I believe when the 13 original colonies formed in the North American continent, farmers were required to grow hemp. Somewhere along the line, we've lost our way, I think.
Yeah. In this book here, one of my favorite books, The Emperor Wears No Clothes, they talk about the history of hemp in our country and how you used to be able to pay your taxes with hemp, which is cannabis. Mm-hmm. And yes. It wasn't, you had to pay with a processed form of clothing or fuel, and you can pay it with raw cannabis that was used for medicine, food, building materials, and so forth. So it's facts that you're talking about, and to bring us to where we are today, whereas our healthcare system is not balanced, there are communities that are either geographically racist, racism or sexism has separated them to a point where they're not getting access to care. And when and bringing in cannabis into this picture, it happens even with our product, with CBD products, because if someone goes to a chiropractor for a case or for insurance, and insurance will cover certain procedures and certain things, but they don't cover certain things. So they could get a prescription for opioids that would be covered by insurance, but
Yes.
a less harmful medicine like cannabis that could treat someone naturally is not. They'd have to pay out of pocket.
Correct. Right. And that's why I say, as a nation, I don't think this is what we want. You don't want your health based on your zip code. And then another thing, that we saw during COVID, was the onset of telemedicine. And I think there were some scientific studies also that showed people in remote areas, if they had access to the internet, which maybe they do, maybe they don't. But that was a way for people to access care. And now that the pandemic's been declared over, I think as of May 11, I think the ability to use telemedicine for things like Suboxone, we have a 6-month grace period, and then this needs to go back to in-person. And what I'm hearing in some medical communities is patients and providers are concerned because patients were able to access this treatment modality that can be life-saving for opioid addiction. And if the telemedicine process was working, should we demand or should it be regulated? That now that it needs to be.
Yeah. So as a healthcare provider or clinician, who do they talk to? They talk to their supervisor and bring these concerns up to them, because this video should be shared across the internets. And if you're a healthcare provider listening that wants to make a difference, because we all have to step up and make a difference. You can't wait for somebody else to do it. What do you advise them?
Well, the telemedicine issue, I believe the DEA is taking comments on that now. And I think they're getting a lot of good comments from providers and from patients. Another thing that moved forward is that the Suboxone X waiver that a provider like myself was required to have, you need to take education, but also that barrier has been removed to allow more providers to prescribe some of these treatments to help with the opioid epidemic. So that was a step in the right direction. But when I see studies like this come out, and when I meet with a group of like-minded people, like I did last week at the School of Pharmacy for the 3rd graduating class, I knew that it had been rescheduled. I couldn't remember if it was the UN or the World Health Organization. The president of Americans for Safe Access was there, and she educated me. She re-educated me about what I had forgotten. And I thought, gosh, if I forgot, I've been talking to people, a lot of people never knew it happened. It did get kind of lost in the forest with what was going on with the COVID epidemic, pre-vaccine in the healthcare community, because that was a pretty chaotic time. So anyway, now that we're talking about it and I'm talking to people, I was communicating with somebody, there's a foundation that I'd been working with, and the young person that stepped up to the plate using cannabis has a better quality of life, is now able to participate in a sport that he loves. And now the ruling body on this sport wants to drug test everybody. It's rather punitive. And that is what got me thinking about, the UN just rescheduled it, and 53 countries recognize it has medicinal value. So why are we still denying, access to CBD, to our military, to our athletes? There have been studies, and the US government put a patent on CBD because it was shown to have neuroprotective effects. For our athletes, wouldn't our athletes benefit, if they had head injury, from CBD? These are questions we should be asking, especially with our young athletes. I mean, these are young brains. We need these young brains.
Yeah, and if we have new data, and if there's new data that's out there, we need to use this, and everyone has to push it themselves, and we have to take the veil off of this misinformation and not focus on blaming of why we got here, even though it is important. But we need to make a change, and we need to focus on the steps that we can and look for the positive opportunities to apply this and demand change.
Yes. Yes.
If you think we're not talking about something that's really that it's not even debatable at this point. There's science, there's data enough to back it up. And when you put it in context to the current situation, right? The current medicine that's being prescribed, it should be fair playing field. So you can honestly demand some change.
Yes.
That's great, Renee. And was there anything else that you wanted to cover today on this topic before we shut down here?
So when you say, well, where do we go to discuss this? Because my world's been healthcare. One of the women I worked with, she created this brilliant project, a brilliant PowerPoint presentation with continuing education credits for nurses, and she works with faith-based nursing. It's an organization, and she created the PowerPoint so that nurses in the faith community can learn about cannabis for spiritual uses, medicine, recreational uses, use, risk, side effect, benefit. But she wrote it out for the faith community. What a great place to start. I think that we need to get our community organizations engaged in this, our school organizations, our universities. And then I think, like I said on the previous podcast, I heard one of the previous presidents of the Society of Cannabis Clinicians say, if our state university, if our clinicians are not going to educate themselves about cannabis, maybe it needs to be part of the licensure process, and maybe there needs to be legislation that our state universities begin teaching the endocannabinoid system, which is a great idea. We don't want to just teach we don't want to just educate our new providers, but the ones that are already in practice. Like I had said before, and like I hear other giants in the cannabis industry say, cannabis could and should be not the only option, but it should be considered in shared decision-making with patients as a first-line treatment option among other treatment options. To not talk about it is doing a great disservice, and it's causing immeasurable harm to our population.
I love your message, Renee. Thank you. And you deliver it so well. And it really hits home with a lot of us. And we just keep talking about it. So thanks again for joining us today. And we will be back again with some more information to keep the conversation going. Everyone that's listening, if you have any comments or questions, you can put some down in the notes. We do monitor them. Even though this is live, after the live show, we do monitor them. And Renee, what's a great way to get in touch with you?
People could get in touch with me through you, or they could email me to the Maryland chapter of Americans for Safe Access, or Veteran Initiative 22.
Okay, that's great. Yeah, because I know a lot of people have questions that are specific based on your experience. So we value that. Thank you so much again, Renee, for the talk. And we will be back more with some more information for you about this cannabis as medicine topic with Renee Reisinger, very credible. And thank you very much for listening. And
thank you. Bye-bye.